Okay. Good afternoon, everybody. I hope everyone has their lunch and everyone feels good and excited for the session. I know I'm excited. My name's Gordon Arbus, and it's a pleasure to be here. It's so nice to be in person and see familiar faces and actually talk to people in person. What a novelty. So thank you to Gilead for putting on today's presentation. And thanks for their support. And just to let you know that the slides that we've constructed today are our own views. And land acknowledgement, I just want to acknowledge the land we are meeting on is the traditional territory of many nations, including the Nitassinan, Innu, and the Wendake Nior-Wensio, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Quebec City is covered by the Huron-British Treaty of 1760. The objectives of today are to evaluate the key learnings from current clinical research to improve HIV care for migrant people living with HIV through linkage to care and optimizing long-term health-related outcomes, to assess community-based partnerships to identify future opportunities for delivery of care for high-quality care in migrant and newcomer communities in Canada, and to apply best practices from multidisciplinary HIV care to current and existing community collaborations. So the agenda will be that I'm going to start off the panel discussion. Very privileged to have with us Ken Monteith from CAHR, who's going to talk about a project that he's involved with, Cercle Orange. And then the Ontario HIV Care Pathway, led by OER, Alexander Roberto from Latinos Positivos. And then we're going to have, hopefully, a discussion and questions from you, if you're so inclined, for the last part of the discussion. So I work in Toronto in clinical care at St. Michael's Hospital in the Department of Family and Community Medicine. And Ken is the executive director of CAHR in Montreal. And OER works in Toronto as a community support worker for PWA and is also on the board of directors and chair of Latinos Positivos and is director of LGBTQ affairs for the Canadian Hispanic Congress and is also a board member of HALCO and advisory committee board member of OAN. So very busy guy, and it's great to be working with you guys. So just disclosures, here are our disclosures, and I want to start off by saying that I'm not an expert in migrant health necessarily, but I will tell you that I've been working for over 25 years with patients every day who've come from over 56 countries. So I hope that I can offer some clinical insights into what we're talking about today. Most of what you're going to learn today will be coming from Ken and OER, who are actually doing the work on the ground. So I just want to talk about some of the clinical experiences and research with migrant and newcomer communities. The outline will be talking about a little bit of epidemiology, some clinical issues and data, further exploration of the issues in terms of a case that I'll bring up, and then some of the solutions locally and resources that may help in working with this population. And so this is a very timely discussion. I think that we're all aware of what's going on in the world, people being displaced from countries like Ukraine and Sudan and South America, Central America. And I think we need to be doing a better job in this country. And this has all been in the news, the recent closing of Roxham Road, for example. And I think there's a lot of pressure on our politicians to be doing a better job. And I don't have all the answers today, but I just want to put it out there that we need to be doing a better job from a political aspect and policy aspect, and also in terms of the care that we provide to our patients. So this is just a stat showing the number of migrants that test positive for HIV. You can see that the numbers are gradually going up and up and up. And there was a drop in 2020, and that's likely because the system essentially was sort of stopped because of the pandemic. So the total number of migrants that tested positive in 2020 is lower than 2019 due to the impact of the pandemic. But you can see up until that point, and I anticipate the numbers are just going to be steadily increasing, which behooves us to be doing more in addressing this issue. And this is just the Government of Canada immigration level plan. So you can see overall the number of planned permanent resident applications is only going up. And a lot of those are, economic, some are family, and then in terms of refugees and protected persons, the number is sort of going up from 22, 23, and then 2024 looks like there's a bit of a drop. And then the humanitarian and compassionate reasons are sort of going up and down. But again, over time, I believe these numbers are only going to be going up. And if you look across the country in terms of new diagnoses of HIV, you've probably seen this graph, this map several times, but it's a really very prominent issue in provinces like Saskatchewan, Manitoba. Some of that is fueled by immigration and refugee patterns, and some of that is fueled by Indigenous populations, substance use. But also, if you look at Quebec, also the numbers are relatively higher than the national average. Again, because what you're seeing is immigration. And in terms of this data, for most jurisdictions, the data for 2021 excludes cases that have been previously diagnosed outside of Canada prior to immigration. So that's important to take into account, that this graph may not be encompassing all the sort of immigrant populations or migrant numbers that we are seeing. So what do the guidelines tell us? And you've seen these guidelines many, many times, and this is sort of ideally how we should be doing things. So everyone who comes into care should be seen quickly, should have a complete medical history, and a physical exam, and obviously a laboratory evaluation, and should be counseled regarding the implications of having HIV infection. And the initial discussion that we do with patients should encompass, talking about the benefits of antiretroviral therapy in terms of their own health, in terms of preventing transmission. And really, we need to sort of talk about strategies to optimize engagement in care and for people to adhere to their treatment. So that's really what we should be doing every single day in the office, which we try and aspire to. And we know that in addition to diagnosing HIV, we need to do sort of baseline testing in terms of figuring out what someone's viral load is, their CD4 count, if there's any resistance that they may have, and various other tests that we do in terms of STIs and hepatitis B, hepatitis C, in terms of those comorbid conditions. So this is what we kind of know that we need to be doing. And we need to ideally be doing this quickly. And there is sort of a push to kind of get everyone onto antiretroviral therapy, and there's good data to support doing rapid start. So depending on the guidelines, there's various regimens that we would utilize for rapid start. Most prominently would be bictegravir, FTC, TAF. But depending on the guidelines in Europe, they may offer a PI option as well as the integrase options that you see here. And so there is good data to support getting patients engaged in care, getting them linked to care, and getting them started on antiretroviral therapy. And you can see that there's good data that show that if you do rapid start, it increases the likelihood of getting people to stay in care. They build trust with you. You're offering something that's going to benefit them. Obviously, it helps in terms of virological suppression. And it decreases the likelihood that they're going to be lost to follow-up or get sick and die. So this is really important data. So we know that accelerated antiretroviral initiation can lead to improved clinical outcomes for our patients. And there are guidelines that talk about engagement in care. So there's the CDC guidelines that basically say you should be starting medical care and antiretroviral therapy, ideally at HIV diagnosis. You should be continuing their treatment in terms of education about the benefits and risks of antiretroviral therapy and the importance of adherence. In terms of DHHS, similar, let's get patients started on antiretroviral therapy immediately. And you do this in order to increase the uptake of ART and get them linked to care. And also, you want to decrease the virological viral load and improve, the sort of outcome for that patient and decrease transmission to potential partners. IAS USA has a very similar sort of strategy, as does the World Health Organization. So I think that everyone's come together in terms of different guidelines to say, like, we need to get people engaged in care. And then there's also guidelines in terms of how we retain people in care. And so there's CDC guidelines, DHHS guidelines, IAS, that ideally all say the same thing, that we need to develop strategies to facilitate immediate entry into care, to remove barriers to the initiation of antiretroviral therapy, and to provide ongoing supportive care as well. So there's just nuances and distinctions with these various guidelines. But what really happens in reality, and this is sort of what the crux of the issue is here today, is there's some good data to show that there are certain populations that unfortunately do not access care as well as other populations. So this is the Canadian HIV Women's Sexual and Reproductive Health Cohort Study, or CHEWOS. And it's a prospective clinical cohort study of women living with HIV in Canada from 2013 to 2015. So they looked at almost 1,500 patients. And they basically found that 3% of those, these are HIV-positive women, never accessed HIV care. And these women were more likely to be Indigenous, have unstable housing, have experiences of racism, and they were associated with an increased odds of never having accessed care. And then when they looked at the other chunk of patients, 97%, they found that 29% reported delayed linkages. So that's greater than 3 months from the time that they were diagnosed until they were linked to care. And again, this was associated more with the age at the time of HIV diagnosis, being Indigenous, being from African, Caribbean, Black communities, or other non-Caucasian ethnicity. Also associated with years since diagnosis and acquiring HIV through injection drug use were also associated with an increased odds of being delayed in terms of their linkage of care. And then 4% were not engaged in HIV or care at all. So women living with HIV in Canada face unique barriers to HIV care, including younger age, unstable housing, history of recreational drug use, and having experiences of racism. So this is the crux of the issue, where we need to find these vulnerable populations. We need to sort of help them to do a better job. And we need really more formal programs to target these social determinants of health. And then this is a project from McGill, where they were looking at sort of the delayed linkage to HIV care among asylum seekers in Quebec, the province where we are right now. And this was a retrospective cohort study from June 2017 to October 2018, looking at 139 patients. And the majority of these newly diagnosed asylum seekers actually presented late to care, and only 45% were linked to care within 30 days. And in these asylum seekers, the majority of the acquisition actually happened in their birth country. But once they were able to be linked to care, the viral load was suppressed quite rapidly. And they found that over 20% of these patients had baseline resistance to at least one antiretroviral agent, and the K103 mutation was the most common mutation. So the majority of these newly diagnosed asylum seekers were actually late to presentation, and over 21% overall had baseline resistance. So I think that it behooves us to do a better job trying to do point-of-care testing, identify these patients quickly, and get them screened and considered quickly into getting linked to care. And so a lot of this is fueled by stigma in terms of why some of these things are happening. So stigma may impact all the steps along the HIV care cascade, which obviously affects someone's long-term health. So this may be because a lot of the communities may have a lack of family and community support. There may be negative attitudes towards certain key populations. There might be fear, societal fear. And people might be getting denied healthcare services. So I think that it happens at each of these sort of timelines in terms of that diagnosis. There might be a fear or refusal of people getting tested. There might be sort of a distrust of the healthcare system, fear of disclosure of their status. And then, people may not be retained in care because there might be stigma just appearing at a clinic or sort of having to wait in the waiting room and fear of having their HIV being seen or disclosed. There might be fear of having to take medication, which sometimes happens. And I think that that's a big one, that people are fearful of being seen taking medications, and so that might lead them not to be adherent or wanting to take medication, therefore leading to decreased chance that they're going to have virological suppression. But we can overcome stigma, and I think that that's a lot of the work that's being done, and you're going to hear about it shortly, in terms of advocating for our patients, providing support to their families and education, doing healthcare training around HIV stigma, and empowering individuals really to, and communities to address discrimination, which happens. And that will, by doing that, that'll lead to an increased awareness of people's HIV status, increasing access and adherence to PrEP, for example, increasing chances that they'll get linked to care, and will be more likely to be retained in care. And that'll lead to more chance that they'll be initiated on antiretroviral therapy and adhering to their treatment, which will lead to decreases in viral load, increasing chance that they'll be suppressed. And that is very empowering for patients in terms of U equals U, knowing that they will not transmit to their partners. And that leads to improved patient outcomes. So I just wanted to sort of talk about a case that I've been involved with, and this is just illustrative of many cases that a lot of people in the room might be working with. In terms of, this is a patient, a cisgender female patient of mine from Ethiopia, who came to Toronto in 2012. She'd been living with HIV since 2010, and she's staying in the suburbs of Toronto with her sister, which is a little distant from downtown where I work. And her children, she left her children back in Ethiopia, and the children are living with the grandmother in Ethiopia. Her husband, unfortunately, passed away of AIDS in 2011. And she sees me on the first visit and says, you help me. I don't know anything. I don't know the language. I don't know the city. I'm living with my sister, which is stressful because my sister's, doesn't want me to stay for long. And she has not been on her medications or had much medical care for some time. And she's basically saying, I don't know if I should stay in Canada, if I should just go back, but I'm afraid to go back. I'm afraid to be here. I want to try and bring my kids here. How would I do that? I don't really know what medication I was on. I forget the names. She's very anxious about being able to stay with her sister. So there's a question of where is she going to live? So that's a lot to kind of digest and try and help someone with. But this is why there are issues that need to be explored and barriers that need to be explored. Obviously there are systemic barriers, and so language is one that potentially might cause some challenges. Just accessing care is a challenge for a lot of people, and that's not only primary care but specialist care for her medical needs. There's the cost of medication. We want to initiate medication again, but how will we access that? How will she access that? She has financial concerns in terms of not having much in terms of savings. There's housing concerns. Where can she live? She can't live with her sister for very long, and where will she go where she feels comfortable and safe? There's a lot of fear and discrimination that she's encountered and stigma, having been a racialized woman living with HIV in a new country that is unfamiliar to her. She has a history of trauma where she's encountered famine and war. She's widowed, and she's had to leave her family and community behind. And then there's legal issues that we need to talk about in terms of, how will she bring her children? Will she be able to bring her children to Canada? And then there's the medical issues of, she's unclear of her medical history and her treatment history. And, ideally we want to get her introduced to care again and on treatment. And there's questions of, did she have any sort of AIDS-defining illnesses? Has she been unwell in the past? And potentially is there resistance in terms of starting her on antiretroviral therapy again? We need to kind of understand what she's been on and if there's potentially any resistance. So, you need a team to help, right? In terms of you got to provide comprehensive care that's sort of biopsychosocial in nature, and that requires a lot of care and resources. So I'm fortunate where I work, I have a team of people. It's not just me, but it might be the nurse that's helping me, the nurse practitioner, pharmacist, dietitian, social worker, psychologist. We're lucky we have all these people at our disposal. The care has to be sort of trauma-informed care that takes into account cultural issues, that's caring, that's flexible for her. We're lucky that we have a language line that we just sort of call up, and whatever language people need, we have interpreters and that really help. We have a social worker, and I think that there's a lot of needs here in terms of all the things that she's encountered and faced and the traumas that she's encountered. Housing support worker, we've engaged a housing support worker to sort of explore where she could live and where she would feel safe. Depending on the situation, we have linkage to care workers, retention to care workers at various organizations in a city like Toronto, and peer navigators. And depending on where you live, you may be able to access those things a lot more easily than other places. So I feel fortunate to be in a big city where we have a lot of access to great services. We have an income support security worker who looks at sort of how can we get more income for this woman. Flexible access to medications, depending on whether she has intrareferral health or whether we need to kind of tap into other programs like the Gilead Max program, for example, or other programs. And then we have access to legal, resources, HALCO in Ontario. Even in our own hospital, in our own program, we have a health justice program, which really helps with immigration issues and housing issues and other legal concerns. And then there's other resources. So depending where you are, these are the things I've tapped into for sure in this woman's case, whether it be, sometimes we have to access care through something like the Blue Door Clinic, whereby they provide care to anyone who's uninsured. And that's a wonderful godsend, although I've just heard recently that they're going to have to close because they don't have any space and they don't have a way to pay the workers who are working there. And it's, it's sort of like just a Band-Aid approach, but it's a wonderful service. There's Canadian Mental Health Association has a great website for newcomers. The ethioassociation.org is for, again, looking specifically at this woman's needs in her own community. So this is to help people who've come from Ethiopia. Jewish Vocational Services Toronto has resources in terms of potential job opportunities for newcomers and refugees. There's other employment websites. Fife House has been a godsend for us. Black Cap. The HIV Legal Network and HALCO. Katie is often a great site as well. And then Latinos Positivos and PWA in Toronto. So I'm sorry I'm speaking like Toronto-centrically, but that's where I'm most familiar with the resources. And then I just wanted to speak lastly on some great work that was just presented. I wasn't there, and so I see Bertrand here, and I don't know if Anish is here as well. Hi, Anish. So thanks for your great work, and I don't know if people saw this, but you could speak to it better than I can, but I was intrigued by this. I just was sort of doing some research on my own, and I found this, and so this is the great work at McGill that's being done. It's a preliminary experience in clinical outcomes for migrants living with HIV enrolled in the ARV Speed Access Program, or ASAP. And basically what they did was it took place at the Chronic Viral Illness Service at McGill. It's a 96-week prospective cohort study that was started in January 2020 in the middle of the pandemic. And basically all enrolled patients received free Biktarvy as soon as possible after being linked to care. The treatment was dispensed on site. The costs were covered from a multidisciplinary team composed of the physicians, nurses, social workers, pharmacists, and a psychiatrist. It incorporated a sample of 50 vulnerable patients. 37 out of 50 were international migrants to Canada. And this was the timeline of the study. There was many interviews that were conducted at 3 different time points. And the interviews were analyzed via a framework method. And then there was the experiences were categorized based on a 7-step HIV care cascade. And then he got 30 categories were identified, capturing the experience of migrants living with HIV across the care cascade. This is a very busy slide, but suffice it to say that they did interview questions that were sort of looking at all the various timelines of the cascade, from diagnosis, linkage to care, treatment initiation, retention and care, adherence, viral suppression, and health-related quality of life. I won't get into the specifics, but suffice it to say that within this model, migrants were able to experience very efficient, humanizing, and holistic care. And they felt that their biopsychosocial issues beyond just their physical needs were being met very well. And alongside this free, rapid, and on-site treatment, patient-centered approaches to care motivated these migrants to be engaged in HIV care and treatment. So I thought it was a wonderful project. I don't know if I captured it fully, but in the time that I have, I just thought it just caught my eye, and kudos to you for the great work. There was also a second part to the study, where they looked at data for 31 out of 37 patients who were enrolled, and they wanted to look at the median time to the initiation of the Biktarvy and viral load undetectability from linkage to our clinic. So they were calculated and compared between the subgroups via survival analysis. And basically they found that the median time to treatment initiation and undetectability for the whole study sample was anywhere from 0 up to 60.5. And the only significant difference identified via a subgroup comparison was that those with insufficient health coverage took a median of about 30.5 days longer to reach undetectability. And so, 71% initiated treatment within 0 to 1 days, which is incredible, and 87% within 0 to 7 days. So the feeling is that, this rapid initiation of the Biktarvy is very feasible in this population. Obviously, having free access was necessary to ensure the rapid start in this population. And almost 30% had no health insurance or health insurance without coverage for HIV care and or treatment. So some of these patients had to access CIDEP Plus for free blood tests, which seemed to delay the fact that they got to undetectability by about 30.5 days. Thus, the shorter time to undetectability seems linked with getting access to free blood tests. So it just goes to show you just some of the small things that we need to think about in terms of how to increase the success for our patients, especially coming from other countries. So this was presented today, and again, kudos to you. I think it's very important work, and I went to McGill, so I feel an attachment to this work. So good work. I'm going to pass it on now to Ken, who's going to speak about Cercle Orange. And thank you very much.
Hello, I'll just introduce myself a bit. Ken Monteith, I'm the Executive Director of CAHR. And when we say Ken doing work on the ground, that's not what an Executive Director is. But I have a fabulous team of people who do the actual work on the ground, and that's important to recognize. I also just want to recognize that I'm a person living with HIV, and anticipating something that Ower's going to say, I take 18 pills a day, but I have more problems than just HIV. So before we go on to the detail of the Cercle Orange, I wanted to talk about a little bit the problem, so setting the stage for it. And everyone who's worked in an HIV organization has had this experience. Someone walks through the door, they're not from here, they need treatment. And often the solutions for those things have been very improvised. So organizations know a friendly pharmacist who might be keeping some things aside, a clinic that is receiving returned drugs from people who are switching drugs, and they can be redistributed. And sometimes there's informal sharing of medication between people living with HIV that I think is important to recognize, even though we can't sanction it. But it's a systemic problem that needs a systemic solution. And that's really just important to understand, that individuals presenting at multiple organizations is, it's demonstrating the systemic problem, and the solution has to be more rational. Something that CAHR did was in 2018, 2019, we had CAHR funding to do a catalyst research project, and it was a number of interviews with care providers, with people who didn't have healthcare coverage, and with people from public health. And we really wanted to sort of paint a portrait of the situation, of the need for universal care for people living with HIV without regard to their immigration status. We sort of characterized a little bit, and we'll see that in who participates in the Cercle Orange, that there are many kinds of people who don't have access to healthcare coverage in our society, and we're trying to address that. So the project also sought to define some short-term solutions to permit access to care, and luckily for us, at the same time, there was an enterprising young person in one of our member organizations who developed the Cercle Orange. And it came to CAHR in 2020 at the beginning of the pandemic, because the organization that was supporting it didn't feel like they could continue supporting it in the context, and so it came, and we were happy to receive it. So, essentially we often talk about two-tier healthcare systems. We have a three-tier system that citizens and permanent residents, if you're not from Quebec, you don't recognize that's the healthcare card, the carte soleil that you see up top. But there are other people who have access to the federal interim health program, the interim federal health program, which is kind of iffy because it's it doesn't necessarily cover all the same things. It's hard to find a doctor who is willing to accept that. And then there are a bunch of people who have nothing and accept their own money and their own resources. So foreign students, temporary workers, irregular immigrants, visitors, and we see those. And another group that I will put in there, because we'll see it later on, is also Canadians who move from one province to another. There's that 3-month delay before you can get coverage in your new province, and you're supposed to theoretically have coverage from your old province. Not so simple. So for us, the components of healthcare for HIV, I'm going to simplify this, so not that busy slide that we just saw, but you need a medical consultation for your HIV. You know that people living with HIV have other problems, other health problems too. They need to be addressed. Laboratory tests and medications. So very simple. And the problem with all of that is that everything costs a lot of money. So a medical consultation, I think citizens were spoiled to be able to go. We present our card. It costs nothing. Laboratory tests also covered, but they cost hundreds of dollars for people who don't have coverage. And medications, I think we all have some awareness of how much they cost, but there are programs that are available for people who have healthcare coverage. So what does the Cercle Orange do? The Cercle Orange built a network of clinics and doctors who were willing to see people for free for their HIV. So it's important that we have a big network of clinics and doctors, because you don't want the burden of having the non-paying patient all on the same doctor. So we distribute them, and we distribute them not only in terms of making sure that the burden, I don't like to think of it as a burden, but the work is shared, but also we're able to match people to doctors who have appropriate experience and appropriate orientation in their work. We have an agreement with the CDEP+, for all the laboratory services. So eventually the doctors will order them, but people will go to the CDEP+ to have their samples taken, and the results will come back through the CDEP+. And then, just for people who don't know, the CDEP+ CDEP means in French, Service Intégré de Dépistage et Éducation et Prévention. So they are services that are largely about HIV and STBBI prevention. It's part of the public clinic system, but the CDEP+ is special because they don't have to, they can see people anonymously. And so you don't always find that in the system. So that was our door to getting access to their connections for lab testing. And then we use the patient support programs of Gilead and ViiV particularly, which provide 100% coverage for the medication that is prescribed. So how does it work? There's my complicated slide. But the person contacts us, has an initial assessment, is referred to medical, to a doctor, and sometimes when it's urgent, we have been able to send someone directly to the CDEP+, and the doctor there does the first prescription so that they can have access, and then they get hooked up with a clinic outside. But we also we have a network of community-based legal information resources, especially specializing in immigration and refugee issues. And so we encourage people to go there to start working on regularizing their status so that they will have access to the coverage. And then references also to community. So our members, the project is based in Montreal, so our members in Montreal don't ask people for their papers at the door. They offer all kinds of support programs with respect to food, social supports, psychosocial activities and interventions, and those things are provided for free. And so that sort of broadly is the healthcare that's offered. So who are we seeing? I'm having trouble reading that, so I'm going to turn my back on you a bit. But it's mostly, you can see that it's mostly men. And this is important, the age of the people who are participating in the Cercle Orange, 66% of them are between 21 and 40 years old. And so that becomes very important later in terms of a public health interest. The next thing is a region of origin. And we did a little manipulation because we didn't say we had originally North America, but North America includes Mexico. We moved Mexico into Latin America because it seemed logical to do that because it's a different situation. But you can see there's still people from Canada and the US, a larger group from Latin America and the Caribbean. We have people from Asia, people from Europe, people from Africa. So really coming from a lot of places. And then we'll see what's their status. So there are a number of people without, these are numbers, those are percentages, these are numbers of people. So a certain number of people without status, a number of students. So students who are, foreign students who are coming, don't have access to healthcare. Temporary work permits, no access to healthcare. Tourist visa, obviously no access to healthcare. Citizens and permanent residents, so these would be the people who are changing provinces. And refugee claimants, and then unknown, because we're not the government, so we don't ask everybody to prove everything before they get help. So what are the results? In the Cercle Orange, we have 104 people who are still currently active. We have a number of people who were able to access Quebec healthcare coverage. We have some who moved away, and then some we lost. We presume they moved away, but they didn't tell us. They have every interest in staying in the program if they're still in Quebec. And the results, really, for those 104 active participants, 102 of them were undetectable, 98%, and the other 2, it is because they hadn't had their follow-up exam yet. So, you know, I think that we know that in Canada we do an excellent job, that when people are on treatment, it's really effective and it works. So how are we doing in this little scorecard? What we've been able to do with the Cercle Orange, yes, medical consultations for HIV, yes, laboratory tests, yes, medications, but not medical consultations outside of HIV. So we have limits on what we're able to do, and we consider that the Cercle Orange is really a Band-Aid solution. So it's depending on charity and charitable gestures to provide health care, and that's not the way that health care needs to be provided. The sustainable solution for us, the cure for this situation, is that every person on the territory has full access to health care without regard to their status. And that's extremely important for us. We are a member of an international coalition, and we see countries that are a lot poorer than Canada who are able to do this. We just had a meeting in the Dominican Republic. The Dominican Republic has a program where the government is providing HIV treatment, but PrEP also to Haitians crossing the border. We have members in South America, and there's an exodus currently from Venezuela, passing through some countries and arriving in Argentina and Chile. Those places are providing health care. And we should be able to do that in this country. But until we're able to do that, we still need the Band-Aid because it's still bleeding. So there's the website of the Cercle Orange. I encourage you to go look at it. It's available in English, French, and Spanish. And that's me. And I'm going to just present Ower. There's a little introductory video, and then Ower is going to talk to you.
Latinos Positivos is a non-for-profit organization that provides services to Latinos living with HIV in the city of Toronto. Hola, mi nombre es Ower Alexander Roberto. I'm the chair of the board of directors of Latinos Positivos. At first, I enrolled with Latinos Positivos as a client. Needed some services, and then, through my life experience, I wanted to, give back to the community. So I enrolled with the volunteer group, and since then I've been, supporting my community. At the very beginning of the HIV pandemic in Venezuela, the medication was covered free and universally to everyone, but the political situation and the crisis increased the shortage of HIV medication.
Latinos Positivos has been a great help for everyone that comes from Latin America, especially because it's a safe space for a lot of people that don't speak the language, they're new in the country.
I've been an activist for 12 years, so when I moved here, I was just trying to continue doing the same thing. So I found out the perfect place, the perfect spot, the perfect group to work with, and it was Latinos Positivos.
Right now, we reached to the point that we have 300 community members registered with Latinos Positivos. Thanks to the support that we have through the partnership with Gilead, we are very hopeful to growth as an organization and to provide services to people living with HIV, especially those that are coming from Latin America. As a Latino living with HIV, I encounter systematic barriers. I know all the difficulties that we have to have access to those services. So through those lived experience, we created like a kind of network to help people when they come to Canada. They don't necessarily need to prevent their HIV care or to encounter the same barriers that I encountered when I came here.
Juntos podemos terminar con la epidemia del VIH para todos en todas partes. Hola, thank you everyone. It is an honor for me to be here in front of you, bringing the voices of hundreds of Latinx folks living with HIV, especially those who are holding a precarious immigration status. Can mention some of the barriers. And we're going to be seeing during this presentation the systematic barriers that many persons living with HIV have to encounter moving here to Canada. Thank you, Randy, because this picture was taken by Randy, and also inviting the Latinx community to be part of the U equals U campaign. Well, during this presentation, we're going to be seeing the main systematic barriers, as I said, like immigration status, language, network, private insurance, social economical issues, emotional well-being. We've been seeing how the peer navigation role is important to help to address those systematic barriers. It connects people with a community belonging, trust building, we conduct this assessment, service navigation, interpretation, advocacy, and we become like chosen family. And how the importance also of building like community allies among the AIDS service organization, but also immigration law firms and free legal clinics, healthcare providers, social services case workers, mental health counselors, peer navigators, and community members. Okay, I know that can also mention how many pills. So I'm a person living with HIV. I received my diagnosis in 1999. So in 2020, I took like 12 antiretroviral treatment per day, plus other medications for gastritis. But I'm happy that now in 2023, I'm taking just a tiny pill, thank you, Gilead, for Biktarvy, which is amazing. And I came here in 2014 as a visitor. So I entered to Canada with a visitor visa. And it was the first barrier that I had to encounter, no? Not having access to healthcare. I was called undocumented, and I said, no, I'm not undocumented. I have my passport from back home, so it's just that I don't have a Canadian documents. It prevented me to have access to healthcare and medication, so that's why I have to stop my medication for 4 months until I had the coverage of IFH when I became a refugee claimant. And this is something that we see every day at Latinos Positivos and PWA. So persons that arrive to our organization looking for medication. And it's something that, as you can see in the picture, it breaks our heart when we cannot get the medication, because we've been told since the very beginning when we received the diagnosis that the importance of adhere to that medication. And then we came here thinking that, Canada, developed country, will have medication regardless their immigration status, but no, it's not the truth. The second super important barrier is the language, and it's a barrier that is not necessarily only affects Latinx folks, as persons speaking Spanish or Portuguese, but also from other communities. And I remember when I came here and I wasn't able to say one word in English, I just hear like blah, 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 or everything sounds like Chinese to me. And it was so difficult to communicate and to look for resources, because some of those resources were in English. And I remember that I was giving information like pamphlets in English and say, okay, well, what I'm gonna do with that. So now it's 2023, I have a smartphone, so I can do certain Google translation, but at that time I wasn't able. And the healthcare insurance, super important. Like every day, persons that are holding precarious immigration status, hence, they have like zero access to medication or to see a doctor and having blood work, and I can also mention how costly it is. So thank you to the patient program. When I talk specifically about the Gilead patient program, that has helped many persons to have access to their HIV medication. Some of them that they're coming from Latin America, they have old-fashioned medication, but we have seen an influx of new immigrants from Latin America that are already coming with a prescription of Biktarvy, so we don't want them to fail in, adhere to the medication, so we want to enroll them quickly with healthcare so they have access to medication. And another barrier is a lack of community. So when they arrive here, not knowing the language, not knowing where to go, some of them, they do the research and find information in Spanish through the Latinos Positivos website, and they find the address, and they go, but none of them live in Toronto. There are people that come to different places of Canada, and talking about Ontario, they come to work in the farms, or sometimes to work in construction in another cities. And there's no resources for them available. So that's why it's a big barrier that prevents them to get links to care. And I've seen many cases, like by being a peer navigator, when I visit them at Casey House, I have to see them die because it was too late. And it's so, it's incredible that still in 2023, things like that could happen. And it shouldn't be happening. And no income. So many persons, when they come here, obviously they don't hold a work permit, hence it's so difficult for them to find a functional job, and they have to work in very precarious employment conditions, that they even receive less than minimal wage. So they don't have even enough money to put food on the table, let alone to pay medication, which is super costly and needed. And so this barrier prevents many people even to have access to see a doctor, because I'm talking specifically about Ontario. The access to HIV medication and also access to healthcare is not free and universally for everyone that is here in the city. I was asked many times, what is your insurance? And yeah, I had a travel insurance, but it's just for basically for accidents, but it doesn't cover any doctor's visit, medication, blood work, and it's something that is preventing many people to have access to healthcare, and then eventually they get super sick. Obviously, it's gonna, everything that, those barriers is going to contribute for really not feeling well, to be isolated, and sometimes, eventually, those to this barrier, people feel like that the only option that they have is to just stay at home, not going out. Some of them using substances, could be from alcohol or other recreational substances, and we don't want this to happen. So that's why the importance of the AIDS service organization and what we do at Latinos Positivos is to be a community for them, so they feel that there is a place where they belong, where they can speak the same language, and where they can see persons who have lived experience. For example, when I do that engagement with them, I also talk about my lived experience, how I came here as a visitor, and this is very important to trust, building trust with them, because for many persons, it's not easy to talk about their immigration status. They think that they're going to be deported if somebody knows that they're HIV positive, or they feel that they're kind of a burden for the system, and they don't want to mention that. But when we talk with them and say, this is a free and safe space where you can talk about your issue, we just would like to know more about what are your challenges, to see how can we help you. And talking about our own experience, it helped a lot to build that trust. And through, when we build that trust, we conduct this needs assessment to see how can we help them. We want to go beyond only providing center information, but actually providing something that is going to be like a long-term solution. And this is the role of the peer navigators. So peer navigators build the trust with community members. They provide interpretation, and they go beyond interpretation. because they also do advocacy. They see resources that are available, and sometimes we have to challenge the system because there are certain times when, you know, healthcare providers or you know, service provider in general, uh, obviously because everything it has to be covered through health insurance, uh, we challenge them. You say we need to help this person. You see this situation, and talking about Toronto, we have built a network that is being connected to many healthcare providers that support Latinx folks, but in general, persons that are on their visitor status and persons who are international students, for example, as well. Okay, so I mentioned that we provide interpretation, and we go beyond interpretation. We do advocacy. I mentioned that we don't want only to provide medication, but goes beyond. What is your situation? What are you fear to go back to your country? What is going to happen? And through this, we understand what are the paths that they can use, and we connect them with free legal clinics such as HALCO, but also we connect them with lawyers that are willing to provide certain free time for legal advice. We help them to connect with resources that are available in the city, and we eventually become their chosen family. We are most of the time the numbers for reference when they are starting looking for employment, because those folks who eventually they hold the precarious immigration status become a refugee claimants. Some of them, they have granted their immigration status, and they become protected person, permanent residents. I went through all this process, so it's the importance to have like family members away from home is something incredible. Like for us Latin American person, we are super happy. We want to always to gather, share food, especially during the holiday season, even in summer. So we continue with this tradition away from our homes here in Canada. And the linkage with the AIDS service organization is important, and the support among the AIDS service organization is important as well, because every organization is going to provide something. For example, at Latinos Positivos, we have this post-prevention program, we have peer navigators as well, and we have counseling. But we rely also on other organizations for practical services. For example, I don't know, PWA, Food Bank. If we need to, if somebody needs to do the taxes with the tax clinic at the ACT. So the service that every organization provides is super crucial for our organization. So that's why the importance of people being linked to the AIDS service organization. And yes, healthcare provider, so we cannot do anything without a healthcare provider, because here in Canada, in order to have access to your medication, you need a prescription. It's one big barrier, the prescription, because some of them, they come with a prescription from back home, which sometimes is easy to understand that it says, for example, I want to talk about Biktarvy, Bictegravir, M3VC, and tenofovir is basically the same in Spanish, but it has to be under a licensed healthcare provider. Here in Canada, and even if somebody has the money to pay the medication, they will need a prescription. And for those who doesn't have any health coverage, they will need that prescription in order to have access to the healthcare, to the patient program. So, healthcare provider, thank you so much for supporting our community. The immigration law firms, but talking about Ontario, I mentioned already HALCO, and some lawyers that they have connected with us, and they are providing free of cost 20 to 30 minutes of legal counseling to assess the situation. And we help them from the peer navigation perspective to apply for legal aid, because sometimes it's a very, although sometimes they can call and we provide an interpreter over the phone, but the peer navigators, they do a lot of advocacy. And through those advocacy, they can understand the situation that many persons are facing. So because it's not like something that for everyone, in talking about equity, it's not for everyone have a different situation. So sometimes are people that are here in this country for more than 2 years, for example. So they call to legal aid, they say, oh, you've been here for more than 2 years, you've been working, blah, blah, blah. So they don't want to provide us a legal aid certificate. But if somebody's there, and I did it a lot of time from Casey House, you see this person is here, hospitalized in Casey House, he's, with their permission, I asked them if it was okay to disclose certain things about their situation and explain so they understood that this person really needs that certificate because it's the thing that is going to link them to healthcare. The mental health, super important. As I said that before, when we don't have, we don't have the linkage to care, we don't have access to the medication, it affects a lot our mental health, and we sometimes end up being isolated. We have counselors, I mentioned that, social service. Okay, it's working also the relation of helping persons when they already have a immigration status that allows them to apply to social services while they receive their work permits, and it happened to me. It's important to the person that has something to cover their medication and also have some financial assistance. And this is the role of peer navigators I mentioned. And finally, seeing the community members being thriving, having a home away from home, and in the end, they're going to be part of the society as I did with my own experience coming from a person without any immigration status to right now being here that I'm a Canadian citizen. Thank you very much.
So we have a few minutes for questions. If there's any questions from the audience, I believe the microphones are set up, so please feel free to come up. And while people are coming up, maybe thank you guys for your insights and experiences. And I guess as a healthcare provider, and for all the healthcare providers out there, how could we be doing a better job to help you help our clients?
I think the first thing that you need to be able to do is be political. That's the community is formulating its demands and what it seeks to change in the government, and you add a lot of credibility to that. We know that you're on our side, you're doing the work with us, but I think that you need to be able to step out of that a little bit and be political and contribute your professional opinion to the debate.
Yeah. Yeah, it's interesting, Ken, that you say that because we have these CanMeds roles that we're all sort of taught in terms of what we should be doing as healthcare providers, and one of them is health advocate. We focus a lot on being a medical expert or a scholar, but I think a really important aspect, especially if you're doing HIV care, is to be an advocate, and we need to do a better job, especially in the current climate where it seems very divisive in terms of what we're hearing out in social media with regards to trans care, and it just boggles your mind. Like, I don't know if anyone's on Twitter, but it's very toxic. And at the same time, I have mixed feelings because I think it's important for us to be advocates, and sometimes social media outlets is a good way to be an advocate. But thank you for your point. That's really important.
I just would like also to add that being beyond providing the prescription, but engage with them in certain conversation on if they have any coverage, what is their immigration status. Because I've seen, for example, just a case that I saw last week, a person that is new to the country, doesn't have any immigration status, has the diagnosis here in Toronto, and was prescribed medication that it wasn't covered through any patient program, and the person has to do like a kind of GoFundMe to pay the bill of that medication. So it would be easier to engage with them in conversation, ask them if they have any way of coverage, and see if they have any, challenges with their immigration status, and perhaps doing this linkage to other organizations where they can find support and information.
Yeah. Thank you. Thank you. Maybe we'll open it up. I don't know if there's anyone out there. Yeah, hello.
Hello.
Sorry, the lights are really bright.
I came early. Yeah, but my name is Mary Ndongo. I'm from Women's Health in Women's Hands Community Health Center. I'm the health system navigator there, and I'm also a registered social worker. I am here just to talk about what I see on the ground as I'm supporting African and Caribbean Black women living with HIV. I had talked about this in the earlier session where I see a lot of women who don't have coverage, and linking them to care is, it's like a big, big headache. So I wanted to talk about the systemic issues and the wait times in everything. So if I have a woman who is just, newly arrived, doesn't have a place to stay, I have to help them navigate getting into the shelter. It takes about a week or two to even get someone into the shelter in Toronto. They don't have medication. I have to make sure that they are linked to a doctor. That takes time. Beyond Blue Dog Clinic is now closing, which was really supportive to us. And also, I thank Women's Health in Women's Hands because our pathway to care is like, immediately they are able to get a prescription from the doctor and they're able to do intake and assessment. So in our end, as a community health center, we make sure that the woman is seen rapidly, but accessing the medication becomes a problem. Accessing mental health supports becomes a problem. We are seeing increasing wait times, in everything. So I just wanted to ask you panelists and also you, doctor, what are the wait times in your clinic, and how are you addressing these things in terms of people accessing you and mental health services and housing supports? You talked about Five House and Halco. I've referred my clients there, but there's also wait times, and staff also are burnt out. Some staff never came back to work after COVID, and so organizations can do so much. There's limited funding, and at the end of it all, our women are suffering, or people living with HIV are suffering based on all these issues. So I just wanted to know your thoughts around that and how we can navigate that collectively.
Yeah, I mean, thank you so much for your question, because I think this is the crux of the issue, and your point is well taken, that people are suffering as a result of the fact that we don't have a comprehensive plan. It's really a hodgepodge of, finding out who is available to see that patient, who can see them for free, because if there isn't insurance. How do we access medication? There's various sort of routes to access the medication, but I must say there isn't like a standard approach, right? It's very sort of ad hoc, which is, I think, the big problem. And then the wait times is just a function of a dysfunctional healthcare system, regardless of what province you're in. I think we're all experiencing the same issue, especially for mental health care access. So, I mean, I rely on certain services. At our own clinic, I believe we provide a very good comprehensive care, product, but we're part of a hospital, so we're limited in terms of the fact that we're a hospital, and the hospital might charge a fee on top of a physician's fee. So for myself and my colleagues, the physicians say, like, I don't care if I don't get paid, but if they're registered as a patient at our clinic, they might get a bill from the hospital, which generally they don't pay. But it's another barrier, right? And so I think community health clinics, at least in our area, like Regent Park, for example, or your clinic, generally they'll have the physician or nurse practitioner that can see them. The medication piece generally is, the companies themselves have been very generous, like Vive and Gilead, for example. But you got to piece this all together. And then there's the mental health piece. So we have a social worker and psychologist that can see people. But a lot of organizations are having huge issues accessing mental health. So at the end of the day, you're right. We need to do a better job, and people are suffering as a result of it. So I wish I could come and tell you today, I have all the answers, but I think you've illustrated a couple of examples of again, a Band-Aid, solution. It's not a definitive plan, but it's a Band-Aid, and I don't know if you guys have ideas.
When people come to the CAHR homes, they don't wait too long. It really takes them a couple of weeks to have an intake interview and be matched with a doctor. And most of them are not in such an urgent situation. They've come, they have maybe some meds for the next month or two. But in situations where it's much more urgent, we have had a collaboration with the CDEP+, which gets them to see their doctor so that they don't stop taking their medication. But again, our service is very limited. It's only the HIV treatment. I know that CAHR has a member organization that is developing, that's a housing resource, that is developing something that will be able to receive people without status in their housing resource, to give them, a sort of transitional place to sort of to get control over their situation and be able to go back out afterwards. But our intervention is barely funded. We're at the stage right now where we're piecing together little bits of funding to continue. And you've mentioned the Blue Doors closing because it doesn't have resources. I think there's a very serious problem with underfunding, especially a lot of community resources. We need stable and recurrent funding.
Yeah. And I just would like to add that due to the situation with Blue Door Clinic, we are trying to ally with other organizations to support Blue Door Clinic for sure, and also those organizations such as HQ and the PrEP clinic is being, we are having conversation with them to see if they can take some of the patients, especially those who doesn't have insurance, or they hold a precarious immigration status, but when they already have the coverage for IFH, so engage with other doctors, just knocking the door, doctor, are you seeing patients? It's like going to basic, so because for sure, and I've seen so many doctors that I'm going to be visiting pretty soon, because some of the persons that they hold a precarious immigration status, they're going to have a coverage, either IFH or OHIP when they become protected persons, and they are entitled to receive health care through a regular pathway as any other person here. So I believe, because I'm in Toronto as well, I can visit you this week, and maybe we can have some conversation how to support each other.
Thank you. Just one more thing. You don't have to answer, but also I'm thinking about people living with HIV who are having other comorbidities, which is what I'm seeing now on the ground. Women, who are being diagnosed with different kind of cancers, and also don't have insurance. So in future, we also need to see how we can support these women. Thank you.
Thank you.
Hi. Hello. I think I'm just here to plant a seed. My name is Michael Parsons. I've been positive since 1986. I live positive in Ecuador. And my last trip to Ecuador, I brought my wife and daughter back with me. So this is kind of a historical thing, and I'm hoping that maybe we can start to look at these issues. When we got to Canada, of course, my daughter automatically had her Canadian citizenship, right? Because we did that overseas. But my wife landed on a visitor's visa, and it was very, very difficult. And especially where, she was mostly dealing within the Latin community. Well, she was a travel agent in Toronto. So she was mostly dealing in the Latin community, and she would always tell people he has cancer, because the stigma is so strong in the Latinx community that she knew she would lose her clients if they found out that I had AIDS, right? And then, so we went through all of this, and I think it was 10 years of working illegally and dealing with all of this stuff, and tens of thousands of dollars, because there's all kinds of bloodsuckers out there that are extracting money from you right, left, and center, whether they can do anything or not. What kind of supports do you have any supports in place for Latinx women and children, or men and children who are married to a positive person. I think this is a really big, big gap. And as I'm sure you know, it's not realistic. It wouldn't have been realistic for my daughter to stay with me and send her mother back to Ecuador. That's just, wouldn't even cross our minds. It's so ludicrous, right? Because the family, the Latin family is so bonded in such a way, I think maybe not so much like other families, right? And I think the seed that I really wanted to plant is we really need, because helping us is one thing, but in order to really help us, you need to help our loved ones as well. And I remember back in the day, you know, I was on welfare, my daughter was on my welfare check, my wife was not. I went into AIDS Committee of Toronto to the food bank. We got food for me, food for my daughter, not for my wife. You know, and these things are very, I'm just hoping there's some kind of change, and if there isn't any change, I just really wanted to plant that seed for you about how important it is to our health as positive people to have support for our family. Thank you.
Thank you. Thank you.
Maybe I could just say something.
Yeah.
I'll just say, you know, I'm kind of surprised to hear a community organization not extending help to someone who is there. I don't think that happens in our organizations. And just in terms of the whole problem with immigration, I think that's one of the reasons that we've made partnerships with people who know more about it than we do, so that they can help and accompany people. But there are lots of organizations that are community-based that are going to receive people without judgment and help them through that complicated process.
And I just would like to add that at Latinos Positivos, we provide services to families. If one person is living with HIV, regardless if the wife or husband or children are living with HIV or not, they are included. And in PWA as well. So if somebody is registered as a community member, their family will receive also essential market. We call our food bank essential market because it's very similar to the experience to go to a supermarket. If somebody has family, they will receive more food because they have family. In Latinos Positivos, we have a counseling program where many serodiscordant couples go to talk about not necessarily only HIV, but other situations such as immigration. And through the alliance with the legal clinic, for example, I have to mention Halco if it's in Ontario, we help them to navigate those complexities. So if you are in Toronto, please don't hesitate to visit us.
We have time for one more question.
Sure, hi. I live in Durham region, which is urban, suburban, and very largely rural. Every year, our population increases by 3,000 to 6,000 people as workers from Mexico, Guatemala, Thailand, Jamaica, Hungary, and other Latin American countries come into Durham to work. Now, technically, they're protected through OHIP, and they have medical access, except the only day off is Sunday when everything's closed. And also, you can't get a doctor in Durham because there aren't any. And if there is one, there's a waiting list of up to 6 years, plus there's a language barrier. We have 4 universities in Durham as well, and a swath of international students. And we find a big problem with that is that if you have insurance to the university, the medications you receive are reported on your insurance back to your parents. So if you want to access PrEP, if you're a young gay Saudi man, then your father and mother will find out you've accessed PrEP, or if you're positive that you're on treatment, and that can lead to a beheading when you get home. So there's multiple complex layers to this. I'm really pleased that you included international students and migrant workers in your comments today, because they're so often a forgotten population. We had funding during COVID. We've been doing migrant work off the side of our desk for 14 years or longer, and we finally had a little bit of funding during COVID to assess COVID risk within the population, but now that funding is gone. And we've sort of created this expectation of service, and now we can't follow through with it. And so it's really frustrating. I'm sure you must echo this, that there are sort of band-aid responses constantly to these really marginalized populations. So what can we do as a sector to really lobby or insist on recognizing that populations, even though technically they're served under the system is so broken it doesn't support them, and we need money for aid service organizations and community health centers to actually be able to go out and meet those populations where they're at to actually have effective medical care.
Yeah, I mean, thank you for your question, and your point is so well taken. We know in especially like Durham region or southwestern Ontario, for example, and I'm sure there's parts of Quebec where they're completely underserved in terms of access to healthcare, period. Never mind HIV-sensitive healthcare. And so, I mean, just an idea I have in my mind is recently Queen's University is setting up a program to train doctors who are going to be family physicians or primary care doctors. And I think the idea is to try and not only train people in that community in Durham region, that's where it'll be located, but the idea will be to try and get them to stay in that region to provide the care. So that's, again, it's a small solution. They're starting with 20 spots in the medical school, but I think it's a good start. And, you know, unfortunately, like myself, I have a lot of patients, and I'm sure a lot of Toronto providers in the audience are seeing people who are traveling great distances from Northern Ontario, Southwestern Ontario, Durham region, and that's not fair for people to have to commute and spend money and their time to get care. But they are coming, and I will see them, but it's not ideal, right? Like, they should be able to get care in their own community, especially if they're coming as migrant workers and working the farms in the community. They should be able to get care in the community. So we have a lot of work to do, but there are small things that I'm starting to see that are changing. And I don't know if you have experiences with this issue.
I just want to say that one of the things that we're trying to do with the CAHR is to illustrate that, you know, even if maybe the government doesn't care about those individuals, there's a public health case too. So, you know, all of those people who, you know, 2/3 of our participants are between 21 and 40. That's a very sexually active time. And so we have 102, probably 104, undetectable people instead of being detectable and able to transmit. You know, we also have seen in the last few years, we've seen that it's possible to drop some of these requirements and to extend care to everyone for COVID testing, COVID treatment, Mpox vaccinations. We did that, open the doors, everybody gets it. And I think that, you know, public health demands that we provide care for everyone on the territory. And if not, it will harm the health of the people who are citizens too.
I just would like to add that as a temporary solution, I've seen persons coming from Hamilton, also from the Niagara region, persons that are working in the farms, and they have been seen by Blue Door Clinic or HQ or PrEP Clinic, and what they do, they try to accommodate and deliver their medication every 3 months. I know that is something temporary. They should have their healthcare providers in those regions, but just in the meantime, they are engaged with their medication. That's also the importance of every healthcare provider, pharmacies, know about those programs, because all of them, they don't have any insurance. And if they receive a prescription that is not covered through the patient program, they're basically doing nothing. Or even worse, sometimes people go to, you know, big pharmacies that they don't know anything about those programs, and they ask them to pay for the bill of the medication. So they are knowledgeable about their situation and accommodate and deliver the medication every 3 months, so they don't need to commute every time to see healthcare.
If I could just add one other thing, is that I think when we're thinking about this whole situation, we have to bear in mind that those people aren't all bringing HIV into the country. Many of them are contracting HIV in the country. Yeah. And so why is the country not responding to their needs?
Yeah. Thank you, Ower. Thank you, Ken. Thank you to everybody. We are going to continue the discussion next door from 2:30 to 3 in the poster area. So if you're interested, we will be there to carry on the conversation. Thank you for attending, and really enjoyed this. So thank you for the opportunity. Have a great day.